This conference will now be recorded.
If we are working in dry eye disease, and if we are working in a non-invasive, or we want to begin in non-invasive oculoplastic surgery. The history of the dry eye disease is very exciting. It's very important. You can see the different date of the evolution of the history of dry eye. Ophthalmologists have changed many times the definition and the classification of the dry eye. The first definition in 1995, the second more important definition, the DUS one in 2007, in 2012, begin the Asia Dry Eye Society, and in December 2016 appeared the new definition due to about dry eye as a multifactorial disease of the ocular surface characterized by a loss of homeostasis of the tear film and accompanied by ocular symptoms in which tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormality play a etiological role. Maybe this definition is missing a mention to visual disturbances, since in the previous definition of dry eye disease it was included. What about the epidemiology of dry eye disease? Dry eye disease affects hundreds of million people worldwide, between 14 to 33% of the world population, and is one of the most frequent causes of visit to the ophthalmologist clinic. One of the most compelling features of dry eye disease is that it occurs more frequently in women than in men. In fact, the female sex is a significant risk factor for the development of dry eye disease. The average of a dry eye patient is 54 years. About the prevalence, it ranges between 10 and 20% of the population, although in Eastern population can affect up to the 33%, for example, in Taiwan, in Japan. It is estimated that more than 60% of the population over the age of 45 suffers from this disorder. Around 5 million people in Spain, an ocular pathology that mainly affects women, increasing with age, up to 75 to 80% in those over 60 years of age. You can see on the image, in USA, nearly 30 million American adults report symptoms consistent with dry eye disease. According to this new DUS2 classification, we are in front of different types of patients suffering from dry eye disease. Asymptomatic patients with clinical sign, symptomatic patients without clinical sign, and symptomatic patients with sign of dry eye. For us, for ophthalmologists, it's very important to detect asymptomatic patients with clinical sign, because if we have youngest people that undergo refractive surgery in the next future, we need to know if these patients are asymptomatic patients with dry eye disease. Risk factors include advanced age, female sex, Eastern population, smoking, extreme heat or cold weather condition, low relative humidity, use of computer or video display terminal, refractive surgery, corneal and intraocular refractive surgery, very important, corneal and intraocular refractive surgery, contact lens wear, and certain medication, autoimmune disorders, thyroid disease, and diabetes. Dry eye disease can be episodic with transient signs and symptoms, or chronic with persistent signs and symptoms. dry eye has a significant impact on visual function that can negatively impinge on the patient's quality of life. About the blinking time per minute is very, very important to know that you can see that in normal condition, 22 times per minute, but while reading, only 10 times per minute. And while looking at computer or watching TV, only 7 times per minute. We need to recommend our patients with dry eye disease blinking more time per minute. Additional approaches are needed to provide a better quality of life in severe cases of meibomian gland dysfunction and in refractory cases to other treatments. And jet plasma leaf could be a new opportunity given the preliminary result that we can obtain. Ocular surface diffusion in dry eye is due to either a deficit in tear production or excess in the evaporation, although on some occasions both can happen. Between 55 to 86% of patients with dry eye present a dysfunction of meibomian glands, which give rise to a type of evaporative dry eye. Jet plasma leaf medical is a medical device, plasma technology, a generator of plasma discharge, but very compact, very light, and very versatile, because we can use in ophthalmology, we can use in dry eye for treating dry eye disease patients, even in mild, moderate, and severe cases of dry eye secondary to meibomian gland diffusion or severe blepharitis, but we can use too in non-invasive oculoplastic surgery, periocular oculoplastic surgery. If we are working with jet plasma leaf in dry eye disease, we have two options, two possibilities. Working with the golden applicator for plasma discharge to eliminate the hyperkeratinization membrane of the eyelid margin and severe cases of blepharitis and meibomian gland diffusion, as you can see on the right image, or working with the silver applicator for treating patients unresponsive to previous medical management in mild and moderate meibomian gland dysfunction. Normally, in the day-to-day, the 90% of our patients we can treat with the silver applicator, and only the golden applicator in severe cases of blepharitis and meibomian gland diffusion. Currently, we are starting to develop different treatment protocols depending on the severity of each case. Why? Because when we are working with IPL, for example, with LipiFlow, the procedure is the same in all the patients, independent of the severity of the case. For example, with IPL, we 5, 6 flash on the skin, but we have many options working with jet plasma leaf. In severe cases using the golden applicator, and in mild and moderate the silver applicator. But with the silver applicator, we can work on the tarsal conjunctiva, as in this image on the right. All the procedure only working on the tarsal conjunctiva, moving the tip in the line of the meibomian gland, or we can combine the treatment working on the tarsal conjunctiva, on the skin, or even in both sides. And currently we are starting to develop different treatment protocols and compare for the future to have only one protocol for every body. How does it work? Jet plasma leaf medical treatment uses plasma, the fourth state of matter, beyond solids, liquids, and gases, in which electrons separate from atoms to form an ionized gas that's become highly charged, transforming into a continuous flow. Oh, yes, sorry, because we have here a video. Transforming into a continuous flow of plasma that stimulates the formation of new collagen and elastin fibers. Jet plasma leaf works with direct current and a high voltage, which guarantees a very accurate plasma flow. It's very, very important to have very accurate plasma flow. You can see on the right, we have only one device with 8 intensities and 5 applicators. The golden applicator for ablative procedure and the silver applicator for working in cosmetic procedure are even in mild and moderate dry eye disease. Plasma flow produces effect at the cellular level. The mechanism of action is not well understood, but potential mechanism whereby jet plasma leaf could achieve clinical improvement include thrombosis of abnormal blood vessel, heating and liquefying the medium, activating fibroblasts and enhancing collagen synthesis, eradicating the modex and decreasing the bacterial load in the eyelid, modulating the secretion of anti-inflammatory molecules. This is very important today because when we are working with dry eye patients, we need to think about inflammation, because 90% of our patients with dry eye disease have inflammation, reducing the turnover of skin epithelial cells and decreasing the risk of physical obstruction of the meibomian glands. The plasma discharge is generated but safe high voltage between the tip of the device and grounded skin of patient. Due to its very thin discharge, only 0.1 millimeter, 100 microns, it is possible to treat areas around eyes. But is jet plasma leaf medical available for everyone? No. When using jet plasma leaf medical device, electrical current flows through our patients, and therefore it is necessary to make sure that the following contraindications don't apply to the patient: pacemaker, Holter, other implanted electrical device, epilepsy, pregnancy, metal implant in the treated area, skin disease or skin inflammation, acute inflammatory disease, systemic inflammatory disease, any untreated disease, oncological process, and some allergies. For avoiding hyperpigmentation risk in patients with phototype 4 and 5, it is recommended to use a hyperpigmentation cream 2 weeks before the treatment and the second week after the treatment, because it's the complication when we are working with jet plasma is very easy to control. For example, hematoma we have some hematoma, some edema, erythema. The control is very, very easy, but it's very important for avoiding hyperpigmentation risk to use a hyperpigmentation cream in phototype 4 and 5. You can see on the left my personal formula, but today you can find in the pharmacy many brands about hyperpigmentation cream. But I recommend, it is interesting to know that to study the palm of the hand in phototype 2, 3, or 4, if the line are pigmented, the risk of hyperpigmentation is greater, even in patients that you before think, no, this is a very good patients. For example, phototype 2, phototype 3, this is okay. But if the line of the palm are pigmented, the risk in people with phototype 2 or 3, the risk of hyperpigmentation is greater, and we need to treat before the discharge of plasma with jet plasma is treated before with hyperpigmentation cream. When we are working with the jet plasma leaf in severe cases and we are using the golden applicator, it should be emphasized that it is also necessary to cover the ocular surface that you can see here. The smoke from evaporation and discharge itself, if the ocular surface is not protected, it could cause a painful corneal bump. The first medical checkup will be 14 days after the objectively whether the condition has improved, worsened, or unchanged. 2 weeks after the treatment, because the patient is able to tell us if the condition has improved, worsened, is unchanged. If the treatment was insufficient, the treatment can be repeated after 4 to 6 weeks. The last checkup will be 3 months after the last treatment. How is dry eye disease diagnosed currently? The diagnostic evaluation of dry eye disease should include a detailed clinical history of our patients and very complete slit lamp examination with a clinical history and very detailed, and with a very complete slit lamp examination. We will have many information about the situation of the ocular surface of our patients. The tear film stability can cause damage to the ocular surface, and then keratitis and the dry eye disease. And dyes such as fluorescein sodium, Bengal rose, and lissamine green are commonly used. Lacrimal meniscus measurement is well known, the normal value between 0.3 0.4, and the tear film breakup time less than 10 seconds considered abnormal. Both are two tests, very quick, easy to do, and both tests are easy to analyze. Schirmer test, well known for all of you, is still very current in the diagnosis of the dry eyes. It's very current, it's very well known. But today we have the tear film osmolarity. The more important is to know that hyperosmolarity indicates dry eye. Hyperosmolarity indicates dry eye when we are using the tear film osmolarity. And MMP9 or matrix melanoproteinases is a non-specific inflammatory marker elevated in patients with dry eye disease. Attention if your patient does not have proper lubrication of the eye surface. Why? Because an insufficient tear film may impossible to have this good visual quality. After cataract surgery, after corneal refractive surgery, with an insufficient tear film, make impossible to have good visual quality, and we need to detect before the surgery, before corneal surgery, before refractive surgery, intraocular surgery, using, for example, premium IOLs. We need to know what patients need treating before as dry eye disease for to have better result after the refractive procedure. Currently, we use in our day-to-day the keratograph 5 and the surface qualified by Cassini in our clinic, and you can see on the right the different mammographer on the market. We have many options for to have in our clinic some mammographer. For me, it's very important the patient questionnaire. We're working with the different patient questionnaire. The OSDTEX, for example, the Ocular Surface Disease Index, is a simple test created to establish a severity and classification of dry eye according to its symptoms. A 12-question survey for dry eye patients that's been shown to be reliable and valid. Even the OSDI scenes the ocular surface disease index 6. Seems to be a repeatable questionnaire and a good alternative to the full original OSDI for use in clinical practice as well as research. Together with the DEX5, OSDI and DEX5 are the two most commonly used questionnaires in the diagnosis of dry eye disease. But at the end, dry eye is a multifactorial disease with many possibilities and different situations that can influence the evolution of disease. For example, contact lens wears, the different environment, chronic inflammation, menopause, different refractive surgery, blepharitis, Sjögren's syndrome, etc. But meibomian gland diffusion is the most common cause of dry eye. Affects between 55 to 86% of all affected patients. It's very, very important. 55 to 86 of all affected patients, and it is treatable in a very efficient way. The result, when we are treating meibomian gland diffusion, even severe blepharitis, is very good. It's important since in severe cases, inflammation of meibomian gland degenerates in atrophy and disappearance of the glands. And meibography is a procedure that allows us to evaluate the morphology of the meibomian glands in vivo in a non-invasive way and with a little or no discomfort. But I recommend before to do some meibography, if the conjunctival, the tarsal conjunctiva is the inflammation is important, treating before, because we can have inadequate result if we do meibography in patients with a big inflammation on the tarsal conjunctiva. It's well known today that lipids prevent evaporation, lubricate, and stabilize tears. About the dry eye symptoms, well known for all of you, burning, itching, redness, gritty feeling, discomfort in reading, driving, in TV or working with computer, as well as intolerance to contact lenses, blue vision, heaviness in the eyelid, photophobia, visual fatigue, watery eyes, and in some situations, occasional pain symptoms. It is very, very important during the history of our patients to know about systemic and topical medication, because they can exacerbate dry eye symptoms. During the clinical history of our patients, we need to know about the systemic and topical medication that can exacerbate dry eye symptoms. This is very, very important. About systemic medication, many anxiolytic, antipsychotic, anticholinergics, antidepressants, antiparkinsonians, antihistamine, antiestrogen, antihypertensive, spasmolytic, and many topical medication, as you can see here. Between half and 3/4 of all contact lens wearers suffer from dry eye symptoms, and about 1/3 of people who have undergone refractive surgery still have dry eye disease 6 months after the procedure. It is very important to detect asymptomatic patients with clinical signs of dry eye before corneal refractive surgery. Currently, we have many options for treating dry eye, multiple palliative treatment for dry eye, such as artificial tears, which offer improvement from symptomatic discomfort and temporary lubrication. For me, the best artificial tears is when they are hyposmolar, neutral, or alkaline and avoid high concentration of phosphate and preservative. The eyelid hygiene routine is very, very important for treating dry eye disease. Treatment with T3 oil for the modex, gels and ointment more frequent for bedtime. The oral and topical secretagogue antibiotic therapy, I recommend the macrolide because it's well known the anti-inflammatory effect, and in children the erythromycin. But one more time, think about inflammation when we are treating patients with mild and moderate and severe dry eye disease. And we have many options today: corticosteroid, cyclosporin in the pharmacy, the Icarbis, Restasis, tacrolimus eye drop. Even in some cases, we need to use acetylcysteine eye drop. Lifitegrast 5% in USA is possible to use, and PRP, the plasma rich in platelets, and the plasma rich in growth factor are two very good options for treating dry eye disease. The Endoret is the more well-known plasma rich in growth factor. The intraductal meibomian gland proving, hot compresses, heat moisture mask, the manual drainage of the meibomian gland, and the eyelid margin debridement using, for example, Blefex. Even the puntal plugs is today, we have the option today, but it's very important with the puntal plugs before introduce the puntal plug, treating the inflammation. It's very important. 1 week, 10 days before puntal plug, treating the inflammation of the ocular surface. And very, very new is the cyclosporin intracanalicular insert that releases cyclosporin over the ocular surface for up to 3 months at the moment in clinical trial. The intranasal lacrimal neurostimulator is possible to use in USA too. The moisture goggles, very interesting, this option to use at home or in some different situations. And from time to time, we use therapeutic contact lenses. This new device, the TRCare procedure, is at the moment in clinical trial and consists of 12 minutes of thermal eyelid treatment immediately followed by manual expression of the meibomian glands. Maybe I think will be ready in the next month, right? But currently, the two well-known and top technology procedure for treating dry eye are the intense pulse light, the IPL, and the LipiFlow. In short, for treating dry eye disease, I recommend early and aggressive treatment. Why? Because it is a progressive disease. It's interesting to know that fat people have more risk of dry eye, more frequent in women because men are protected by androgen and we don't use the makeup. And in the patients suffering from blepharospasm on dry eye, the botulinum toxin A injection were effective in the blepharospasm. IPL reduces inflammation, facilitates the removal of abnormal fatty material from inside the glands, and it has an antimicrobial and antiparasitic effect on the demodex. A typical dry eye treatment consists of 4 to 5 light flashes applied to each lower eyelid. The treatment is then repeated on 3 or 4 additional procedures every 2 weeks. And the LipiFlow is a thermal pulsation, consists of the localized by Johnson & Johnson, localized application to heat and therapeutic pressure on the fourth eyelid using heat. Normally 42.5 degrees is provided to the inside and outside of the eyelid while they are massaged from the external face. It's very interesting to know that some colleagues that are working with LipiFlow and with IPL combine both procedures, LipiFlow and IPL, even in the same procedure. If you are treating some patients outside your city, for example, you live in London and your patient is from France, you can use LipiFlow and the IPL in the same procedure. But today we have a new treatment approach with jet plasma leaf for treating meibomian gland diffusion and severe blepharitis, because it is very precise and stable plasma flow thanks to use direct current. The margin of the meibomian glands are released, softening of the content of meibomian glands, the meibum, anti-inflammatory effect, elimination. We can eliminate the bacterial flora in meibomian glands and around, and improve the elasticity of the ligament fibers around the gland. When we are working with the golden applicator in severe cases, it's a painful procedure. We need to apply the local anesthesia according to your usual practice in your workplace. Normally, the most of the surgeons use lidocaine 2%, normally without epinephrine. In my group of surgeons, normally without epinephrine. And for this treatment, select an ophthalmological applicator, the golden 14 or 24 millimeter, to be put on the plasma pen. We propose using golden applicator for patients with meibomian gland diffusion refractory to other treatments, with a plasma discharge to eliminate the hyperkeratinization membrane of the eyelid margin and thus block the ducts and orifices of the meibomian glands, and also use thermal stimulation to improve and fluidize the production of said glands. You can see two different cases before and after the procedure with very good result. 1 month after 3 sessions using golden applicator, one more before and 1 month after the treatment. The silver applicator for treating mild and moderate meibomian gland diffusion. Normally, we will use the silver applicator in more than 90% of our patients with mild and moderate meibomian gland diffusion and severe and mild and moderate blepharitis too. I use topic anesthesia using oxybuprocaine and tetracaine in double anesthetic in my country, double anesthetic, virtually painless, just a little, maybe a little discomfort, intensity, depending on the patient's final result at 3 months, but 75% objective improvement with the 1 or 2 sessions. But after the 4th session, the final result will be better. Recommended for dry eye secondary to mild and moderate meibomian gland diffusion, not for severe cases that we prefer to use the golden applicator. The intensity, we can starting with 3 and go up depending on the sensitivity of each patient up to 8. But the higher intensity used, the better result we will have. The higher intensity used, the better result we will have. It's possible. I recommend to use even using topical eye drop intensity 8 for working with the silver applicator. About 10 passes must be made on the surface to be treated on the tarsal conjunctiva or on the skin in both vertical and horizontal way. 4 to 6 sessions are recommended, one every 2 weeks. You can see 2 different videos when we are working in severe blepharitis. You can see it's very fast, only 3 passes on the margin of the eyelid. One more time, it's very fast. 1, 2, and 3 is enough, but we need to local anesthesia because this procedure is painful. But with the silver applicator, we can work on the tarsal conjunctiva, on the margin, and on the skin. In this case, you can see working on the tarsal conjunctiva on the margin of the eyelid in mild and moderate cases using the silver. One moment, because it's important to know. It is estimated that approximately 90% of people with dry eye suffer from chronic inflammation. It's very important. We need to treat before many cases of even before mammography. We need to treat with anti-inflammatory, topical anti-inflammatory corticosteroid on cyclosporine, the ocular surface, before treating the patients with jet plasma leaf or another platform. About meibomian gland diffusion, there are several factors that can aggravate it, and among them the menopause. Why is very important? Because an unhealthy tear film can negatively affect surgical results. Therefore, it is imperative to diagnose and treat meibomian gland diffusion preoperatively before our patients undergo, for example, presbyopia correction with, for example, multifocal IOLs or refractive cataract surgery. And meibomian gland diffusion is the first etiology that ophthalmologists must address, because healthy meibomian glands are key to the health of the ocular surface, and because more women between 50 to 65 won't undergo refractive surgery for presbyopia correction or for refractive cataract surgery. One more time, treating inflammation is essential to break the vicious circle of dry eye and get disease if resolved effectively. Inflammation plays a role not only in severe cases of dry eye disease, but also in moderate evaporative dry eye disease. In addition, before and after the procedure with using jet plasma leaf, I like to use omega-3 in my patients. I like to recommend diet rich in potassium, calorie restriction, and vitamin D control. Herbal food supplement, I recommend herbal food supplement if possible, but read in enough light, avoid very small print, good position for working with the computer, and then regular reviews to the ophthalmologist. Even acupuncture or Chinese traditional medicine working good. In conclusion, dry eye disease, a very common condition, affects the quality of life of our patients, and it has a high social cost for them, in addition to the direct cost of medical and pharmaceutical care. Development of a new treatment for dry eye disease, for example, jet plasma leaf medical, can contribute to achieving stability of the ocular surface in patients with meibomian gland diffusion. Examine the ocular surface carefully and address any problem before considering implanting a premium IOLs or corneal refractive surgery more in youngest population. And jet plasma leaf can be a good option for treating mild cases of dry eye secondary to meibomian gland diffusion. But for me, maybe the more interesting feature of jet plasma leaf is the versatility, because not only we can treat dry eye disease, but oculoplastic, non-invasive oculoplastic surgery, as non-invasive blepharoplasty, xanthelasma with a very good result, ectropion and ectropion procedure, tracheasis, chronic blepharitis, elimination of many lesions, correction of some scars on the face, around the eyes, closed feet, and even smoker line, or even periocular lifting. How many treatments are required? Non-invasive eye lift and skin rejuvenation usually only take 1 or 2 sessions to attain the desired outcome. However, the majority of patients respond positively only after a single session. You will see preliminary result instantly, and the result will continue to develop over the coming months and may last for up to 5 years. As similar to the traditional surgery. Mole, warts, and skin tags removal is one of the procedure. In non-invasive blepharoplasty, you can see the step-by-step, and you need to know that the more important is marking to know very good what is the surface that we need to treat in the non-invasive blepharoplasty and the anesthesia, because the procedure itself is very easy. It's very easy. The training for begin with the non-invasive oculoplastic surgery for us, for the ophthalmology, is very easy. In the non-invasive blepharoplasty, it is an ionized gas that becomes highly charged and add almost like a little lightning bolt that effectively vaporizes and sublimates the safe skin, leaving a fine crusting that disappears after a week or so. The removal of the excess tissue and the heat generated effectively tightens the skin and boosts collagen production. You can see here the different areas of anesthesia that we have when we are working in oculoplastic surgery, even in dry eye disease in severe cases when we are using the golden applicator. We can use 3 possibilities of different anesthesia: the supraorbital, infraorbital, and supratrochlear block. The local infiltration is the most used for the surgeon currently, and the lidocaine cream. But it's very important to know that only when we want to work with lidocaine cream for example, non-invasive blepharoplasty, you need to have the lidocaine 25%. No EMLA, because EMLA is only 10% of the concentration, is not enough to have good anesthesia on the skin if we are working in non-invasive blepharoplasty. We need to have lidocaine cream 25% of concentration. But the most of the surgeon working with the jet plasma leaf prefer to have the local infiltration with the lidocaine 2%. You can see two video about the method for non-invasive blepharoplasty. Before the scanning method of the upper eyelid, in this case, you can see the move of with the tip on the skin. Is very important to have very clear the surface that we need to treat, and is very fast, and is very comfortable for you and the patient is the anesthesia is well done. And then when we are finished the scanning method, we need to do the dot by dot method on the same surface that we before treating with a scanning method. You can see dot by dot using the same surface that we have treated with the scanning method. The look is very similar. Some erythema after the one with one day in the beach is very similar. The look of the eyelid of our patients when we finish the procedure. One more time, scanning method, and then the dot by dot. Even we can have the options to recommend our patients after blepharoplasty, non-invasive blepharoplasty, for example, 6 months after non-invasive blepharoplasty, we can recommend some periocular lifting our patients, or even with entropion, we can to have some entropion procedure, and 4 or 5 months after the entropion procedure, we can recommend periocular lifting for to have better result, only for to treating the lifting or periocular lifting. Even the facial, all the facial area, facial lifting. I like to combine in many cases and recommend the non-invasive blepharoplasty and then a facial lifting. Is a very good option, combined procedure in oculoplastic surgery. It's possible to work on the neck and chest with neck and chest rejuvenation. And now you can see non-invasive blepharoplasty cases before and after. This case is a patient with 4 eyelid before and 1 month after. The procedure is very nice. The look here immediately after blepharoplasty, some erythema, and the control in the post-op is very easy. Even maybe in the second day with more edema, the control of the edema is easy, and the happy will be very happy 1 week after the procedure. One more time, blepharoplasty on the upper and lower eyelid before and after the procedure. The 4th eyelid is normally we can recommend to treat if necessary the 4th in the same procedure for removal of warts before and 1 month after. Very interesting procedure. Recommend. And the xanthelasma is very interesting. We are treating xanthelasma is maybe for begin with just plasma leaf. I recommend together with the dry eye disease. I recommend, for example, working in xanthelasma because the result is very impressive. With local anesthesia, infiltration of lidocaine 2%. And in about the tropion, we need to apply plasma discharge on the skin and on the tarsal conjunctiva, dot by dot, with form of a triangle with a superior base on both sides. You can see in the left the image of the triangle with the superior base in both inside and outside of the eyelid. In all the cases in entropion, we need to treat inside and outside on the tarsal conjunctiva and on the skin. But in entropion, we only need to apply a plasma discharge only on the skin with the same triangle form with superior base. In tracheasis, I think, yes, this is a video for tracheasis. is very easy, but it's a painful procedure, and we need to do local anesthesia. For crow's feet, the result is very impressive. You can see one more time for tracheasis. Okay, and why I speak about smoker line? Because in many countries, for example, in United Kingdom, British Oculoplastic Surgery Society recommend and have the training for treating not only the oculoplastic area, but all the face, and even working many surgeons in United Kingdom, in another European country, on the neck. And the smoker lines are treating for many British oculoplastic surgery with jet plasma leaf as a very effective procedure. And only for bronchial remove on the neck, as you can see on the image. This is the bibliography using for this presentation. And for finish, plasma flow stimulate the formation of new collagen and elastin fibers, improve sun damaged skin, reduces wrinkle and expression lines, and smooth the skin's surface. It is also a good option thanks to its versatility for treating dry eye disease secondary to severe, moderate, and mild blepharitis and meibomian gland diffusion. Thank you for your attention.
Mr. Rodriguez, thank you for your interesting presentation. Thank you very much. And now we are free to your questions. I will open the chat.
Yes, I would like maybe Martin to say in dry eye disease, it's very important to know that 90%, 95% of all our patients suffer from suffering about inflammation. And if we have a patient with a high level of inflammation, even before myography, or even before different procedure, IPL, or using jet plasma leaf, we need to treat before the inflammation using corticosteroid or cyclosporine before the procedure. With jet plasma leaf, we have a a medical device, very easy to the training is very easy for begin with this medical device. But we have two applicators, the silver and the golden applicator. And it's very important to know that the golden applicator is for using in ablative procedure, as for example the blepharoplasty, non-invasive blepharoplasty, or for using in dry eye disease for treating the margin of the eyelid in severe cases, or for remove hyperkeratinization membrane. And the silver applicator will be the more frequent in the day-to-day, because 95% of the patients will have mild and moderate meibomian gland diffusion. We can work with silver applicator and only using just using the topic anesthesia if we prefer to use the tarsal surface for treating the dry eye disease, using the silver applicator, or on the skin we don't need to use nothing. Even maybe in some cases, if the sensitivity of the patient is high, we can use EMLA with 10%, the normal EMLA. And but normally many patients can to have the treatment without cream. And in oculoplastic surgery, it's very important to know that the control of the edema, the hematoma, is very easy and disappear in 1 week, 10 days, no more.
Okay, great, Dr. Rodriguez, thank you. I don't see any questions from the participants, so probably it's gonna be all for today. Thank you very much for participating. Thank you very much, Dr. Rodriguez, for being the presenter for today. Dear participants, if you have also any questions after this presentation, please feel free to contact us and we will answer your questions or forward them to Dr. Rodriguez. I can see that someone wrote something in the chat. I'll open it. Oh, Matlam, hi, hello.
Yes. Hello.
Yeah, I don't. Which Matlam is asking Dr. Rodriguez, which setup level are you using?
Okay, no problem. No problem. For me, it will be a pleasure to share my presentation with all the doctor that today have with us in the webinar. Martin can send the presentation everyone.
Yeah, there is also one question. Which setup level are you using?
Yes, what? It's because the sound is no good today, Martin. I don't understand well. What is the level?
Which?
Yes.
Yeah. Which setup level do you use?
Okay. In general, I recommend for all the procedures in oculoplastic surgery and in dry eye disease, I recommend the higher energy that this is possible. If you have working with 8 intensity is for me the best, because with 8 the result will be better. In general, using high energy, the result will be better in all the different procedures. Only I recommend, for example, in patients with phototype 4 or 5, maybe in the lower eyelid in non-invasive blepharoplasty, I only recommend to do in the upper eyelid the two method, the scanning method, and then the dot by dot. But on the lower eyelid, I only recommend to use the dot by dot using 5 to 6 for avoid the hyperpigmentation risk. For phototype 2, 3, if the patient don't have the line of the palm with hyperpigmentation, I recommend even to use the level 8. But for the majority in Canary Island, in South America, in many Indian population, the phototype is 4 and 5. And in these cases, I recommend to use in the lower eyelid only energy 5, because with this and dot by dot, no scanning method and dot by dot method, only dot by dot and using 5 or 6, no more. This is the best nomogram for beginning with this medical device. But with the mentality, if we can use the high level, the 8 level with this medical device is the best, because the result will be better. In dry eye, for example, we need to do between 4 to 6 sessions. It's very similar the group that working with IPA, no? 4 to 6 different sessions separate every 2 weeks. With the jet plasmalis will be the same. I recommend to do 4 session or between 4 to 6. If we need, if we will need to use more session if we use less energy in dry eye. If the sensibility in the conjunctival area is high and we use only 5, for example, maybe we need to have 1 session more. If possible, I recommend in all the procedure in oculoplastic and in dry eye working with 8 energy. Only in phototype 4 and 5 reduce the energy to 5 to 6 if the phototype is high, 4 or 5, and even in 2 or 3 if the line of the palm are pigmented, and use hypopigmentation cream. This is my regular protocol.
Great, Dr. Rodriguez. Thank you. I think that we covered everything what we wanted to cover today. So thank you very much once more for being the presenter. Thank you, participants, to participate in today's meeting, and have a nice weekend.
Okay, thank you. Nice weekend.